Welcome to those who are beginning to join us. I see we have people trickling in. Thank you for joining us today at this learning community event where we will be talking about updated boosters. Para Español, you'll want to hit that interpretation button at the bottom right hand of your screen, and you will have an interpreter. So welcome again. Thank you especially to the Urban Institute for helping to organize this event, as well as to our CDC subject matter experts who have taken time out of a very busy week to help apprise us of what's going on with these updated boosters. For those who don't know me, my name is Chelsea Toledo. I am a contractor working at CDC, serving as a public health advisor to the Partnering for Vaccine Equity team. It's a pleasure to be here and be moderating this event. Next slide, please. So today we ask that participants remain muted during the webinar, but you can use the raise hand feature. So at the bottom of your screen, you see a little hand. You can use that raise hand feature to be unmuted to ask a question. You can also use, there's a Q&A panel next to that in the taskbar to submit a question at any time. We have live Spanish interpretation, so I do apologize that my Spanish is somewhat limited to tell you that, but you can hit the little globe icon at the bottom of the screen, and you can access this webinar in Spanish, where we have a wonderful live interpreter. And we do ask that the questions go into that Q&A box, because the chat can get a little bit hectic, so it's a little bit easier to manage them in that Q&A box. So just ask them there, and do be civil with your feedback in the chat. For technical problems, please reach out to our Urban Institute team, which can be reached at vaxequitylearning@urban.org. Thanks. The next slide, please. So joining us from CDC today, as I mentioned, we have two subject matter experts. Our presentation will be given by Dr. Preeti Patel, who is a medical officer and associate director in the Division of Viral Hepatitis. She's currently detailed to the Immunization Services Division to lead the fall COVID-19 vaccination strategy happening now. And then also joining us, so as you're typing those questions in the Q&A box, we have a wonderful expert here who will be addressing your questions as well. That's Diana Yassani. She is the lead for the Federal Retail Pharmacy Program and federal partners as a part of the COVID-19 vaccination campaign. And she supports CDC's Immunization Services Division with strategic partnerships. With that, I will hand it over to Dr. Patel for her presentation. Thank you. Next slide.
Thank you so much, Chelsea. It is a pleasure to be here today to talk with all of you. Wish I could see you all on the screen, but really appreciate this opportunity. Next slide. I wanted to start by just clarifying some of the terminology that I'll be using. Unfortunately, I had to pull slides for this presentation from a lot of different sources, so different terms are going to be used throughout, but I'll be using the term updated to mean interchangeably bivalent COVID-19 vaccines, and original to mean monovalent COVID-19 vaccines. So you'll sometimes see those different terms being used, but I intend them to mean the same things: bivalent equaling updated and monovalent equaling original. And I wanted to mention that we were very intentional in our use of the term updated, because these vaccines are truly an updated version of vaccines that we have a lot of experience with. And so I'm hoping through the course of this presentation to share with you information that will be helpful in reassuring individuals throughout the communities that you work with that this is very analogous to how flu vaccines are developed. In other words, the flu vaccine composition changes every year to more closely match the strains that are expected to be circulating during that flu season, but the actual structure of the vaccine itself is relatively constant. And so that's very similar to what we're dealing with these updated COVID-19 booster vaccines. And we tend to use the term updated when we're communicating with the lay public, and bivalent when we're talking to more scientific audiences. Next slide. So I wanted to run through a little bit of background before we get too far into talking about the bivalent booster vaccines and some of the events that have occurred recently. I know that a lot of people probably haven't spent their summer paying close attention to what's happening with COVID-19 and the epidemic. There's a lot of things that are going on right now in the world of public health and that are impacting communities. And so thought it would be helpful if we just run through a little bit of background first. Next slide. So I'm sure that everybody has heard of the SARS-CoV-2 Omicron variant. There are 5 different sublineages, which are not particularly important for people to know, but they do have these titles, BA.1 through BA.5. And the things that are important to know about Omicron variants is that they have increased transmissibility. So they're more easily spread than other variants that we've seen before. And they also can escape our immune defenses better than other variants. But they have decreased disease severity. So many of you may recall that earlier in the year and during the past winter, we had a big surge of Omicron infections. And even though Omicron infections by themselves are not quite as severe on an individual basis as some of the previous variants, such as the Delta variant infection, because so many people were infected and because there was so much spread, there was still a high degree of hospitalizations that resulted and a lot of deaths that resulted. So a high burden of disease, even though on an individual basis, the severity of the disease is not that great. So that's once again our concern as we enter into the fall and the winter months where we know that Omicron variants are still circulating. Since they have such a high likelihood of spreading, we are once again concerned that there will be a lot of spread and there could be a lot of severe illness as a result of this strain. The other thing that I sort of alluded to, which is lower down on the slide, is lower vaccine effectiveness. So the vaccines that we had been using are not quite as effective to the Omicron strains as they were for the strains that circulated earlier when the vaccines were first developed, which makes sense. So what we're hoping to do with this update to the booster vaccines is identify a vaccine that can more closely target the Omicron strains that are now circulating and that can provide better protection for people. Next slide. So this slide shows trends in the reported number of COVID-19 cases in the United States. And there's a couple of things that I wanted to point out. You see the different sort of eras that we've gone through with the Alpha strain and the Delta strain and the Omicron strain. So we are fully in 2022. We have been fully in the Omicron period where where Omicron strains have predominated. And you see that big spike that I was referring to that occurred last winter when we had a lot of cases, a lot of hospitalizations, and a lot of deaths from Omicron. Compared to the spring of 2022, we have seen an increase in the number of cases, not a huge increase, but again, as we move into the fall and winter months, which are characterized by more increased indoor activity and holiday gatherings, we are concerned that there could be another surge as we have seen in past years. And so that's why we're trying to be prepared for that. Also on the left-hand side of the slide is an important reminder of just how much COVID we have experienced thus far as a nation. So there have been more than 94 million reported cases in the country and 1 million deaths that have occurred due to COVID-19 in the United States. And as much as we would all like to be finished with this COVID-19 pandemic, I think we still have some work to do. Next slide. This slide shows trends in COVID-19 associated hospitalization rates. So whereas the last slide showed cases, this one is actually what's the rate of people having to actually be admitted to the hospital as a result of COVID-19. And it's broken down by different age groups. And you can see here that since the spring, hospitalizations have also increased over the summer. So that's on the right-hand side of this graph in this slide. You see sort of an uptick in hospitalization rates that have occurred between spring and where we are now in August. And those hospitalization rates have really most impacted older age groups. So people ages 65 years and older have really felt the brunt of this more than younger age groups. And that's where where our concerns are primarily located, although not exclusively. We want to make sure that our older age communities and populations are protected and have access to the best possible vaccine protection that they can as we go into the fall and winter months. Next slide. So this slide also shows rates of COVID-19 associated hospitalizations over time, but instead of being broken out by age, it's actually broken down by race and ethnicity. And you can see over time that there, of course, have been disparities in hospitalization rates between these different race and ethnicity groups. Those disparities appear to actually be narrowing a bit during 2022 and may be reduced compared to prior times in the course of this epidemic. And that may be a positive sign. However, there are still disparities. And so recent hospitalization rates during the most current period of time since May have been highest among American Indian, Alaska Native, and Black persons. Next slide. This slide provides some information about where we are with COVID-19 vaccinations in the United States. So as of August 24th, there were close to 224 million people who had been vaccinated with a primary series, 108.5 million people who received their primary vaccine series and a first booster dose, and 23 million people who received their primary vaccination series, a first and second booster dose. Obviously, there are differences in vaccination coverage by age, with the oldest age groups having the highest vaccination coverage compared to lower age groups, and also race ethnicity. Notably, we've seen lower booster dose coverage in most minority groups compared to non-Hispanic white populations, and by disability status. So overall, we think this is a huge accomplishment, that the sheer number of people who have been vaccinated as a result of this vaccination program that has had tremendous reach. But of course, there's important differences that we've seen and populations that still require attention and outreach. Next slide. So the bottom line for this slide is shown in the box on the right, and it's less important to actually examine the graph, but I think the message here is really important. This graph shows rates of COVID-19 associated hospitalization by vaccination status in adults. And if we look at that Omicron period of time, you can see that the adults who were unvaccinated, shown in the green line, had almost a 5 times higher rate of hospitalization for COVID-19 compared to people who had been vaccinated with the primary vaccine series and at least one booster dose. So what we really want to make sure people understand is that COVID-19 vaccines have and continue to protect against serious illness. And that includes hospitalizations, as shown here. It includes deaths, which I'm not showing you data for, and it includes infection. But most importantly is really this ability to protect against the most serious manifestations of COVID-19 that will cause someone to end up in the hospital or to die. And this is true for the COVID-19 primary series vaccinations, and this is true for the booster vaccinations. And the benefit of the booster vaccinations, of course, is that over time, people's antibodies and immunity against the virus can decrease. And so the booster helps to increase the protection against the virus that may have been lost over time. Next slide. So just to quickly summarize the public health problem, as of August, there have been over 94 million COVID-19 cases reported in the United States and 1 million deaths. Since April, hospitalization rates have increased, and they've increased most dramatically in older age groups, particularly people 65 years and above relative to other younger age groups. Unvaccinated people, so this is the data that I didn't show you, but unvaccinated people who are at least 5 years of age or older had 8 times higher COVID-19 associated death rates compared to those with at least one booster dose. So again, reinforcing this idea that COVID-19 vaccine is the best way to protect oneself against serious outcomes of COVID-19, including hospitalization and death. And this is particularly important for those people who are at high risk. Racial and ethnic minority groups have been disproportionately affected by COVID-19 associated hospitalization and deaths, as we all know. These inequities have decreased over time, or seem to have decreased over time, but they have not been eliminated. The current vaccines, again, just to reiterate, offer the best possible protection against severe illness and death from COVID-19. It's important to stay up to date with vaccination, including all boosters in eligible populations. And we'll talk more about that in just a few minutes, of course. Next slide. So this slide shows the distribution of different strains that are most commonly causing infection in the United States. And what you see here is that BA.5 and BA.4, these are both variants, Omicron variants, make up the vast majority of infections in the United States right now. And those are the ones shown in the green shades. Next slide. So in order to create a booster vaccine that would be most tailored to the current circulating strains, and ideally also what we are likely to see in the future, in late June, the FDA's Vaccines and Related Biological Products Advisory Committee, or VRBPAC, met, and they voted to include a SARS-CoV-2 Omicron component in the COVID-19 vaccines for boosters for the fall. And then immediately following that meeting, the FDA advised vaccine manufacturers to specifically include Omicron BA.4/5 spike protein to their vaccines to create a bivalent booster vaccine. So this goes back to the slide I just showed you, where BA.5 and BA.4 are the most common strains that are circulating currently and really make up the vast majority of infections. And so FDA took that information and advised vaccine manufacturers to specifically include a spike protein that would elicit an antibody response to these particular strains of the virus. And the reason it's a bivalent booster vaccine is because it actually has two different components in it. So it does continue to have the strain spike proteins from the original vaccine, as well as this additional spike protein for the Omicron strains. And because it's bivalent, it's expected to elicit a broader immune response to a variety of strains. So not just the Omicron and not just the original strains, but a whole range of strains that we might be exposed to, including those that are circulating now, obviously, as well as what might be emerging in the future. Next slide. Okay, so next I'm going to talk a little bit about the most recent events, including FDA authorization of the bivalent booster vaccine and the Advisory Committee on Immunization Practices, or ACIP, recommendations. Next slide. So just a little over a week ago, the FDA authorized the Moderna COVID-19 bivalent vaccine for use in people ages 18 years and older, and the Pfizer-BioNTech COVID-19 bivalent vaccine for use in people ages 12 years and older. And these vaccines are authorized as a single booster dose administered at least 2 months after the last COVID-19 vaccine dose. And that last COVID-19 vaccine dose could either be a completion of the person's primary vaccination series or their most recent booster dose. So it no longer matters how old the person is, other than being at least 12 years or older. It no longer matters exactly which brand of vaccine they received in the past, and it no longer matters how many booster doses they've received in the past. This is intended to really simplify and make more universal the authorization and the use of these vaccines. Next slide. Importantly, when FDA made this decision, they also announced that monovalent mRNA COVID-19 vaccines, or the original COVID-19 mRNA vaccines, are no longer authorized as booster doses for people ages 12 years and older. In other words, they really wanted to replace the outdated version with the updated version. So just to reiterate that, the monovalent mRNA COVID-19 vaccines are no longer authorized as booster doses for individuals ages 12 years and older, meaning the monovalent booster doses can't be given to people ages 12 years and older. We think this is probably for the best in the long run to avoid confusion and misadministrations, for example, of vaccine. In the short term, we recognize that it may cause some challenges. And I'll talk about this more in a little bit. Next slide. Okay, so now I'm going to pivot and talk a little bit more about ACIP and their recommendations. Next slide. So first, just taking a step back, I wanted to mention that the ACIP uses what they call an evidence to recommendations framework. And the evidence to recommendations framework helps them to structure their review of the evidence and helps to guide their determination about recommendations. And you can see the old framework on the left-hand bottom side of the slide that included multiple domains, and one of those domains was equity. After a lot of discussions internally and with external stakeholders and experts, a decision was made to really expand this framework so that equity was not just one element or one domain that was siloed from all the others, but actually would be added to each one of these other domains and in an expanded framework that really integrates equity into the entire evidence to review framework. And so that's the version that you see on the right. Next slide. So when ACIP met to talk about the updated bivalent booster vaccines, this was the first time that they incorporated this new expanded framework. And so for each of these different elements or domains, there was a discussion about not just is the problem of public health importance, for example, but a discussion around does the problem impact all populations equally, for example, and a discussion around these aspects that influence health equity. So I wanted to share that with you because we're excited about this change and the steps going forward, where this will become more part of the norm of the conversation around all of the evidence to recommendation discussions that are occurring in the CIP. Next slide. So we don't have enough time to go through all of the evidence that was reviewed by FDA and or ACIP in their processes. But I wanted to highlight a couple of things for you because I think it's important to know and to help combat some of the misinformation that might be out there or concerns that people may have about the updated booster vaccines. So we have just an incredible, vast experience of using COVID-19 mRNA vaccines for close to 2 years and over 600 million doses that have been administered in the United States alone. So not even counting all of the millions of doses that have been administered worldwide, we have tremendous experience within this country of using these vaccines. And extensive vaccine effectiveness studies that have been conducted, as well as robust post-authorization safety monitoring and data across multiple platforms. So these vaccines, as you might imagine, have been heavily scrutinized and studied. And I bring this up again because just like when we're talking about the flu example or the flu vaccine example, the composition of this particular updated vaccine may have been updated from what it was before. But it is not a new vaccine. It is really the same structure and process that exists for all of these other COVID-19 mRNA vaccines that we've been having experience with for the past almost 2 years, with a slight update, just as we do for flu season every year. And that's one of the things that we really want people to understand is that we do have extensive experience with these vaccines. And they have been studied extensively, and there's a lot of data on their safety and their effectiveness. So specific to the bivalent COVID-19 vaccines, there is clinical data. In other words, after having administered these specific vaccines in humans in over 1,700 persons. That includes the bivalent vaccines with Beta and Omicron variants from different sources. And there's over 1,400 individuals who received the bivalent vaccine with the Omicron component specifically. So again, there is a vast experience with these vaccines generally, and then also data from bivalent COVID-19 vaccines that include Omicron strains. Next slide. So here are the things that we know. And this is some of the information that was summarized during the ACIP meeting. COVID-19 vaccines have a high degree of safety. COVID-19 vaccines provide high levels of protection against severe disease, as I shared with you. And these booster doses further increase the protection against severe disease because people's immunity can wane over time. For most of the population, we know that the last time that they received a booster dose or the last time that they received their end of the primary vaccine series was somewhere between 6 to 10 months ago. And so for most people, they're entering into the fall and winter months without adequate protection for what they might be exposed to in the future. And lastly, bivalent COVID-19 vaccines expand the immune response after vaccination. So of course, a vaccine that includes an Omicron spike protein will improve the likelihood that you're protected against Omicron because you'll actually have an antibody response to that strain. But the bivalent vaccines also appear to provide a more diverse response overall, as I mentioned, likely improving the response to future variants. So not just the Omicron that we're seeing today, but whatever is coming down the pike next. Next slide. I wanted to share with you a little bit of information about side effects from the bivalent booster vaccines, because I know that is a common question and people are concerned about what does the side effect profile look like for these updated booster vaccines. And so these are data for the Moderna bivalent booster. And what is described here is both local and systemic reactogenicity. So in the purple on the left-hand side, you see the frequency of people having local side effects or local reactions. And then on the right-hand side of the slide in green, you see the frequency of people having these sort of systemic reactions where they're kind of feeling icky all over. So you can see that pain was a very frequent and common reaction at the injection site. And I think everybody knows to expect that. Some of these other local reactions, such as swelling, tenderness, redness, were less common or less commonly reported. On the right-hand side, people had fatigue, headache, and muscle aches or myalgia pretty commonly. Some of these other things like chills, nausea, vomiting, and fever occurred, although less commonly. And the reason I'm sharing this is I think everybody who's had a COVID-19 vaccine probably knows that there are some side effects that they might have, and some people may have had a pretty awful time with those side effects. It's important for people to know that these can happen. The reassuring side is that there were no serious events that were reported. So the kinds of things that people have been experiencing are, you might feel lousy for a day or two, or maybe 3. And people should know that so they can hopefully arrange to get their vaccine at a time that's ideally convenient for them if they're going to have these side effects. So again, this is the Moderna bivalent booster. Next slide shows similar information for the Pfizer bivalent booster, although the study was only done in people ages greater than 55 years. So again, you see that pain in the injection site is the most commonly reported local side effect for the Pfizer bivalent booster, and swelling or redness was much less common, whereas on the right-hand side, again, fatigue, headache, and muscle pain, somewhat common and commonly reported, whereas these other things still happen, like chills, fever, vomiting, etc., but much less commonly. And just as I mentioned with the Moderna booster, there were no serious events that were reported in this study. Next slide. So after reviewing the evidence, CDC made the following recommendations. ACIP first made their recommendations, and then CDC chooses to endorse or not endorse those recommendations and can modify them. In this case, CDC recommended the recommendations that were made by ACIP as they were made by ACIP. So the recommendations are: a single dose of bivalent Pfizer-BioNTech COVID-19 vaccine is recommended for individuals ages 12 years and older, at least 2 months after receipt of their last vaccine dose. Excuse me. And a single dose of bivalent Moderna COVID-19 vaccine is recommended for individuals ages 18 years and older, at least 2 months after receipt of the last COVID-19 vaccine. Next slide. The nice thing about these recommendations is they allow us to reset and hopefully simplify the recommendations that people need to understand and implement. So now, instead of having to count the number of doses people have received or understand what age they are or what medical conditions they might have to figure out what the recommendation should be, it is much more simplified for those who are eligible. As this table shows, if you are eligible and you've received the primary vaccine series, which is required to receive the updated booster, and it's been at least 2 months since that last dose, then you should get 1 updated booster dose. If you received the primary series plus 1 booster dose previously or 2 booster doses previously, as long as it's been 2 months since that last vaccine dose, you should get an updated booster dose. Next slide. CDC also modified their up-to-date with COVID-19 vaccines definition. And so the definition now is you are up to date if you have completed a primary series and have received the most recent booster dose recommended for you by CDC. Again, hopefully this will be moving to something that is simpler to understand and easier to determine as the recommendations are more streamlined. Next slide. Now I'm going to talk a little bit about how we plan to implement this, distribute vaccine, and reach the people that we need to reach. Next slide. So as we go into the fall and winter months, we realize that we have certain goals that we can aim to achieve, and also there are opportunities. And so these include our goal of vaccinating all eligible people while focusing on those at highest risk. We want to make sure that people at high risk and those hardest hit communities have access to the vaccine and that they're getting vaccinated and feeling confident in the vaccine. We also want to protect against the circulating variants and offer people better protection against the variants that are circulating now than they would have if they purely relied upon the original vaccines. We have opportunities to simplify the vaccination schedules, which I've talked about already. And we also see a huge opportunity to promote all routine immunizations, including flu vaccine, given that this is flu season that we have coming up. So we're not just aiming to promote COVID-19 vaccination, we're really thinking about this as a piece that fits into the larger picture of routine immunizations and protecting our most vulnerable people against the infections that they could be avoiding. Next slide. We will be leveraging heavily the infrastructure that already exists for vaccine delivery and dissemination. So I think many people may have seen the announcement that the US government has actually purchased a large amount of vaccines. So the bivalent vaccines will be managed through the same sorts of systems that have occurred in the past because they're government purchased. And they'll be distributed through this existing infrastructure and the networks for distribution that we've used all along. Just to share some of those milestones, we've had over 800 million doses in total that have been delivered of COVID-19 vaccine and over 600 million doses, as I mentioned previously, that have been administered. So we feel that we are reaching the people that we need to reach. We have the capacity to do that, of course, supplementing that with efforts to reach populations that may have limited access. Next slide. This slide shows some of the jurisdictional planning and considerations that we've asked jurisdictions and other vaccine providers to bear in mind. As I mentioned, the US government has purchased approximately 171 million doses of the bivalent COVID-19 vaccine boosters for the fall and beyond, and there's an option to increase the amount that they will purchase up to 300 million doses, I believe. The initial authorizations, as I've already mentioned, are for ages 12 years and up for Pfizer and ages 18 years and up for Moderna. However, authorizations for younger age groups are expected to follow. We don't know exactly what that timeline will be, but it is possible in the coming weeks to months that we may see updated boosters authorized for younger age groups. And so that's one thing that we want to be on people's radars, even if we're not ready for that to happen just yet. The current eligibility, I've already mentioned, people must have completed the primary vaccination series. And we estimate that to be roughly 200 million adults who have completed that primary vaccine series who would be eligible for the updated booster dose. And again, it must be at least 2 months or greater since the individual's last primary series vaccine dose or their last booster dose. Monovalent mRNA vaccine is not disappearing from the scene. It's still used to complete the primary series. So it's important to know that while the booster doses have been updated, the primary series doses or vaccine formulations have not been updated. So if somebody hasn't yet had their primary vaccination series, they would still receive the monovalent vaccine for their primary series. We've asked jurisdictions and pharmacies to consider strategies to ensure high-risk populations have access. And this is not an exhaustive list, but we've certainly asked them to consider long-term care residents as being obviously at high risk and needing to have access to vaccine, older adults, homebound persons, disproportionately affected communities, and rural areas. Next slide. So the slide is entitled, "No Need to Choose Between Monovalent and Bivalent Boosters." So this gets back to the issue of the monovalent mRNA booster vaccines no longer being authorized as boosters for people ages 12 years and up. And the goal was to simplify what's available to give individuals who are eligible for a booster so that there aren't two choices that would then potentially cause confusion and misadministrations. So the bivalent booster recommendation replaces the previous booster recommendations for people ages 12 years and older. That means everyone ages 5 years and up who's eligible for a booster dose will now only be eligible for one booster dose. And if they're 12 years and up, they'll get the updated booster dose. And if they're ages 5 through 11 years and they receive the Pfizer-BioNTech primary series, they would get the monovalent booster dose in the short term. Next slide. We get a lot of questions about co-administration of COVID-19 vaccines with other vaccines, particularly flu vaccine, for good reason. So I wanted to share some recommendations around that. CDC recommends routine administration of all age-appropriate doses of vaccines simultaneously as best practice for people for whom no specific contraindications exist at the time of their visit. So the bottom line is providers should offer all vaccines for which a person is eligible at the time, at the same visit, excuse me. With both influenza and SARS-CoV-2 circulating, getting both vaccines is obviously important for prevention of severe disease, hospitalization, and death. And getting both vaccines at the same time or at the same visit increases the chance that a person will be up to date with their vaccinations. Next slide. There have been a lot of studies looking at co-administration of influenza vaccines with COVID-19 vaccine, and those studies have shown that the immunogenicity, or in other words, the ability of the vaccines to create the kind of immune response that we want, is similar between people who received COVID-19 vaccine together with influenza vaccine and those who received the vaccines separately. So, and we expect that the vaccines will still work and will still be effective if they're given together. And you can see the numbers in some of these studies. So there are 92,000 individuals who received a COVID-19 vaccine together with the influenza vaccine in one of these studies, and over 400,000 people who received these two vaccines together in another data registry. Generally, when we've looked at safety information, when COVID-19 vaccines are administered together with seasonal influenza vaccine, there might be similar or slightly higher reactogenicity. And by reactogenicity, I again mean those kinds of local reactions and systemic reactions I talked about before with the COVID-19 booster dose. So things like having redness or swelling or pain at the injection site, or fever or chills or feeling fatigued. Those kinds of symptoms can occur with both of these vaccines. They may be similar in people who get them together compared to people who get them separately, or they might be slightly higher when you get them together. However, there was no specific safety concerns identified. In other words, again, no serious safety events aside from those reactogenicity type events or local or systemic reactions. So I think this can be slightly around personal preference, right? If you communicate to somebody that they may feel lousy if they get both of these vaccines together, they might decide they'd rather do them together and get it over with, or they might decide that they want to do them at two separate times. And I think as long as you feel confident that you can still reach that individual and get them protected with both of these vaccines, then patient preference is certainly important and should be taken into consideration. Next slide. So again, influenza and COVID-19 vaccine co-administration is safe and it's effective. Co-administration, of course, may be a particularly important strategy in some populations or areas, and one should consider the benefits to timely completion of recommended immunizations with co-administration and discuss concerns if patients have them. Next slide. All right, so I'm going to move into a couple of resources. Next slide. I'm going to show you vaccines.gov, which has been updated. Hopefully people are familiar with this tool. So if you go to vaccines.gov, you can now find flu vaccine locations. You can also find COVID-19 vaccine locations, including locations that have the updated boosters. So I will mention that I think by the end of this week, we are expected to have about 15 million doses of the updated booster in the field, which is not everything. So there still may be a lot of locations where it hasn't completely arrived and not quite yet ready to administer, but there will be locations that do have the vaccine. And we expect that as the month goes forward, that there'll be more and more locations that will have the updated boosters in stock. Next slide. So this is what this website looks like if you haven't used it before. So if I clicked on that button that says find COVID-19 vaccine, it asks me to put in a zip code, and then I can choose which COVID-19 vaccines I'm looking for. And for the updated boosters, it's those two that are bolded, which are called newly authorized bivalent in either the 18 and over age group or the 12 and older age group. So you can click on those and it will show you the different vaccine locations in your zip code area. Next slide. And if you choose one of those locations, it will give you more detailed information. So you can see for this particular one, this particular location has the Pfizer-BioNTech updated booster vaccine available for people ages 13 and older. They have that in stock, but they do not have the Moderna updated booster vaccine in stock. And then at the bottom, it also tells you about flu vaccine availability. So this location also offers flu vaccines, so you know about the availability of that vaccine as well. Next slide. And then the same thing for flu vaccines. So you can use the same vaccines.gov site to look for flu vaccine locations. If you click on a particular location, it will tell you which types of flu vaccines are available at that location, including, for example, high dose flu vaccine or adjuvanted flu vaccine or egg-free. And then it also tells you in this case, the location also offers COVID-19 vaccines. Next slide. So a helpful tool, and I hope people have used that or will consider using that in the future. Next slide. So just to recap a few things that we talked about in terms of the updated COVID-19 vaccines and equitable distribution. The COVID-19 vaccines have a high degree of safety. That is true for the vaccines that we've had 2 years of experience with, and it is true for the updated COVID-19 vaccines. They provide high levels of protection against severe disease, as we've discussed. Again, true for the original vaccines and true for the bivalent updated vaccines. And those booster doses further increase protection against severe disease for people who haven't had a vaccination in a while against COVID-19. It boosts their immunity and allows them to be better protected against what they might be exposed to in the future. And these updated COVID-19 vaccines expand the immune response after vaccination. That's because of the bivalent nature of the vaccines and also because it includes a spike protein that will generate an immune response to Omicron strains. So obviously a vaccination that includes some piece of the Omicron strain will improve our protection against Omicron if we are exposed to it. But also we're expecting that the bivalent vaccines will provide more diverse response overall to a variety of strains, including those ones that are likely to be hitting us in the future. As far as distribution and vaccine equity, the fact that these vaccines have been purchased by the government is obviously a plus. It means that people can get vaccinated at no charge, and they don't have to worry about having insurance or meeting other criteria to receive the vaccine. That is all still part of the same vaccination provider agreements that have been in existence all along for this vaccination program. There are important implementation considerations that we talked about, such as the monovalent authorization being removed for booster doses for people ages 12 and up. And we talked about co-administration, which is safe and has advantages that people should know about. overall, education and communication is likely to be important in this scenario so that people really understand what we're talking about when we say updated COVID-19 booster vaccine, and can feel confident in what they're receiving. Next slide. So lastly, I just wanted to thank everybody who contributed to this presentation, the slides, and also thank all of you for all the work you do to improve and advance vaccine equity. I'm going to turn it over to Chelsea.
Thank you so much, Dr. Patel. If we can go to the next slide, I think we do have about 15 minutes for questions and answers. And if we can get through some of these questions, we did have a couple of discussion items we'd like for the group to consider. But if you have not checked out the Q&A panel, you'll definitely want to do so at the bottom of your screen. Diana has been answering questions this entire time, and I just have to commend everyone who's asking questions. These are really so thoughtful. We do have some remaining questions, so I'll just start here at the top for Dr. Patel. How do you recommend addressing the fact that Omicron is seen as less serious and that so many people have had COVID without serious consequences?
Yeah, it's a great point. It is seen as less serious, but we have no idea what we're going to be facing in the fall and the winter, and that's what we're really thinking about. So people need to be thinking about not just what's happening right now in terms of how many people are getting infected or how much the case counts are, how many people are landing in the hospital, but they need to be thinking about what could happen in the fall and winter. And we really want to emphasize that the vaccine is the best possible way to protect oneself from the serious consequences that occur from COVID-19. And that can occur from Omicron just as well as any other strain. It's also important for people to be thinking about the potential long-term consequences of COVID-19. And I know that tends to make a difference for some people. So obviously, if you're vaccinated and if you never get COVID-19, then you're less likely to get post-COVID-19 complications or conditions. And so that may speak to some people about the desire to not just avoid serious consequences from the infection at the time of the infection, but also aiming to avoid spreading it to others or aiming to avoid long COVID.
Fabulous, thank you. Next, I'm just going down the list here. How about boosters in the upcoming future for the bivalent vaccine? So we know that it's only authorized as a booster. Should we anticipate that more boosters of the new formula will be recommended? And any words of advice regarding messaging? So I think this person is asking if we're anticipating additional doses of the same updated booster in the future.
I don't think we know that yet, but what I can say is that there is an interest in moving more towards a system that is similar to how we do routine or repeat immunizations for flu. So the ideal would be that everybody gets their booster / whatever vaccine, seasonal vaccine at a certain period of time. And we don't know exactly what that frequency will be. It's possible that it could be an annual thing. It's possible that it could be more frequent than that. But I think that's the end goal. We just don't know yet exactly what that time frame will be.
Great, thank you. So next we hear that many organizations are seeing a diminishing infrastructure and lack of funding on the local level for mobile vans or mobile clinics, and that impacts access to vaccination. So what are steps that organizations like those on the call should take in ensuring that their community members have access to vaccines?
So we've obviously been communicating with jurisdictions, with pharmacy partners and other partners about the importance of reaching populations that historically may have lacked access. And I think communication, raising awareness, and raising the alarm about this is going to continue to be important. So communicating with those decision makers that you have access to, whether that might be a jurisdictional health department or others, and ensuring that they know the importance of the mobile van, the clinics, the strategies that have been used in the past to reach certain populations, I think is going to be important going forward.
Thank you. I actually have two more because there was one that I accidentally answered. Some people may not be comfortable with getting a vaccine that has not been tested on humans. So while I understand that this is an update, what should we be doing in this case with people who are not comfortable with the lack of human testing?
Yes, so this is the reason that I have delved into all of this technical information that some people may have sort of glazed over during, which is totally understandable. But it has been tested in humans, and so that's really the message: is we want people to understand this is an update. It is similar to what we do with flu vaccine all the time. So the vaccine has been studied in humans. The bivalent vaccine has been studied in humans, and we have vast experience, as I mentioned, with the COVID-19 vaccines that are made the exact same way, that have the exact same structure and scaffolding as the vaccine that we're talking about now. And so we need people to understand and help to communicate to folks and educate folks that we are really talking about apples to apples. It is not a wholly different vaccine. The bivalent vaccine has been tested in humans, and there is a ton of experience with exactly these types of vaccines in humans throughout the world, let alone in this country.
Oh, that's so helpful. Thank you so much for clearing that up. There was one that I forgot about, which is, are there any scientific explanations for the observed decrease in Latinx people getting COVID-19? So cases of COVID-19 among that population, although they are not getting a second booster in comparison to other minority groups.
I'm sorry, could you repeat that?
So I think the question here, and Virginia, I don't know if you want to come off mute, but I think that this person has observed that it's not one-to-one that the cases among Hispanic or Latinos of COVID-19 are not increasing the way you would think, even though they haven't been getting all the recommended boosters as a group.
Yes, so I think the disparity information that I showed you in terms of outcomes was hospitalization. So so that doesn't necessarily reflect what's happening with cases, right? And people who have a case can have lots of different outcomes. Some of them may be hospitalized, some of them might not be, but I don't feel familiar enough with the data to know if there's really divergence between vaccination rate and the outcomes in these particular groups.
Great, and we do have a follow-up question from the previous question about the data on the tests on humans, if those are available.
Yes, so most of that data includes, and those are data that were shared with FDA to help inform their decision around authorization. There's also data that were shared, the same data was shared with ACIP to help inform their decision around their recommendations. And the data largely consists of safety data, which obviously I think a lot of people are interested in, and also data around immunogenicity. So again, this is how good of a job does the vaccine do at creating an antibody or an immune response to the various various viral strains that we have concerns about. That includes Omicron, but also other strains. And so those are, I think, the two main categories of the type of data that are available. Obviously, as these updated booster vaccines roll out, there will be much more information gathered about other types of outcomes, like the ones I showed you for the original vaccines. In other words, how good of a job do these vaccines do at actually preventing infection? So all of that, or preventing serious outcomes such as hospitalization and death. So all of that is things that people will continue to be studying as we go forward. But there are data available on the testing that has been done in humans.
Great, and it looks like we have another question. Latinos used to be known for not getting booster and getting more cases of hospitalization or severe cases. According to the data presented today, it seems like those rates changed given that more Blacks, Alaskans, and Native Americans are presenting higher hospitalization rates. So it's just a clarification on that question.
Yeah, and I wouldn't read too much into those differences. You know, from my view, the lines were pretty close together, and so I wouldn't conclude that there's one group that necessarily has you know, a much higher rate than another. I think it's an important trend that we need to continue to watch, and we don't really know what will happen as we go into the fall and winter months when hospitalization rates are likely to increase across the board.
Great. And then the last question I see is there any guidance or concern with co-administration with the vaccine to prevent monkeypox?
So that is a great question. That is one that I would need to take back and get more specific information on, unless there's anybody else from the CDC side who knows the answer to this.
Yes, it sounds like we're gonna take that one back to our monkeypox emergency response colleagues, because that's a little bit outside of the realm, but that's such a good question. That is all the questions I had in the Q&A panel. I know we do have a couple minutes left if we can go to the next slide. And we have some, sorry, I should have changed the wording on this one. We had a previous discussion with primary recipients of the Partnering for Vaccine Equity program. So for that group, we asked as primes, how did they anticipate engaging with their subrecipients to support this rollout? And so I think what we're asking here on this first one for those who are not primes is like, what do you see your role in this? And what are your anticipated needs? And what are the barriers to making it equitable? So we'd love to hear from you. If you'd like to come out off mute or raise your hand, we'd love your feedback. Thanks. Don't be shy. Oh, I saw a hand. Where did it go? Go ahead. Okay, a hand went up and then down. Well, we did hear in the questions about, some of those barriers being, that lack of infrastructure, lack of funding to, keep those strategies going to meet people where they are, like having those mobile vaccination clinics come into those communities. So I would be really interested to see, what strategies people do to get around it. And we have a comment in the chat. I think more infographics around bivalent boosters, which clarify how primary series will work now that the bivalent vaccines are available. So that's a need. Noted. How do you unmute yourself? Oh goodness, I didn't know we could. I do apologize. They can't speak or mute. Sorry about that. No wonder you're being shy. You can't. Okay. I don't know if we can unmute anybody in the chat so they can speak up, urban team. But I do apologize for that misunderstanding there. So if you want to go ahead and throw some ideas into the chat, I can read it out. And I do apologize that I did not realize you could not unmute yourself. So bringing the vaccines and the vaccine administrators to the spaces and places where people are. So yeah, exactly. Subrecipients population can't scale up easily. Absolutely. They definitely need more materials in plain language in English and Spanish. Absolutely. And while we have you as a captive audience, for those who have not seen this resource, I would like to call your attention to Vaccine Resource Hub. If you have resources that you would like included in this, you may submit them. There's an email address on there if you're not a Partnering for Vaccine Equity partner. But we're adding to it every single day. So please do check that out and see if there's anything on there that can help, and check back, because we continue to add videos in English and Spanish for social platform circulation, educational and short format. Fabulous. And again, do check out that Vaccine Resource Hub link, because there might be something that you're looking for on that. Seconded, especially on TikTok. We have TikTok stuff on Vaccine Resource Hub now. That's new. Will ACL's dial line continue to be available? Dr. Patel, I don't know if you know that one.
I don't know that one, but I can try to find it.
Great. So it sounds like there's a lot of lingering questions here with this one. So for the urban team, it would be really helpful, I think, if we can get a list of who, was here so we can follow up with the questions to those lingering questions, or the answers to those lingering questions. But we are at time. We do want to be respectful of your Friday afternoon. I actually have an appointment to go get my bivalent booster, my updated booster and my flu shot after this. So I hope you all do as well. Here we've got our poll. If you can answer that. And as you're answering, I would like to call your attention to the final slides, which we're going to post to the learning community. For those of you who have access to that, I will see about sending it to those who do not have access, so we can just get that out via email. But there are additional resources in those slides at the end. But with that, we thank you for your attention. Thank you to our speakers for being here. Thank you to the Urban Institute, and thank you all of you for coming. I know it's a Friday, and we just really appreciate all the work you're doing in your communities. None of this is possible without you. So thank you and have a great weekend.